A very good morning to you all. I'm not feeling the energy. Are we here today? Yes, I love that. My name is Dr. Lilian Benjamin Mwakyosi, all the way from the United Republic of Tanzania. It is such an honor to stand before you today to present on a topic: empowering futures, youth involvement in sexual and reproductive policy, health and rights policy development. I'm an executive director for their organization based in Tanzania, where we do a lot of community engagement, promoting community engagement to making sure that sexual and reproductive health solutions, but also HIV response solutions, speak to the needs of the communities we are serving. Next slide, sorry. So with this presentation, I will quickly take you through understanding the youth demographic in Africa, highlight some key sexual and reproductive health rights elements, current sexual and reproductive health and rights issues affecting adolescents and young people in Africa, but also we'll look at some of the barriers hindering engagement of adolescents and young people. Thank you. Hindering engagement of adolescents and young people in the development of sexual and reproductive health policies, but also implementation of those policies. And last, we'll look at some of the recommendations to guide our better practices moving forward. Next. So Africa has the youngest population worldwide. In 2022, as of 2022, around 40% of the population in Africa was estimated to be young people aged 15 years and younger, compared to a global average of 25%. Our young demographic could provide a huge, powerful opportunity for us when it comes to development and beyond. And this also includes increasing impact and sustainability of sexual and reproductive health policies and programs in Africa. Unfortunately, in many African countries, existing sexual and reproductive health policies do not really permit or expressly guarantee young people friendly access to sexual and reproductive health services. This stands as a threat to us and all the huge investments we have made over the years in addressing sexual and reproductive health issues for adolescents and young people. So next, let's take a look at some of key elements I'm going to talk about when it comes to sexual and reproductive health for young people. We understand very well how sexual and reproductive health is such a huge umbrella term, incorporating a lot of sub-elements. I'll mention a few. We have sexual health, maternal health. Specifically for young people, you can't run away from talking about youth-friendly services, legal and policy frameworks, reproductive health, contraception, HIV and STIs, but also gender equality. Equitable access to sexual and reproductive health require us to fully engage adolescents and young people for us to be able to actually maximize impact and making sure that what we are doing and the gains are sustainable. However, we're not able to achieve that if we leave young people behind in the way that we create, develop, but also implement our policies. Here are some of the issues affecting adolescents and young people when it comes to sexual and reproductive health in Africa. We understand very well how access to sexual and reproductive health for youth remain a challenge in Africa, with adolescent girls and young women being disproportionately affected. We have issues such as child marriage, gender-based violence, teenage pregnancies, HIV transmission, and low coverage of modern contraceptive use as such common issues in many African countries. If I narrow it down to HIV specifically, we understand very well how adolescents and young people bear the burden of this disease. In 2022 alone, 480,000 new HIV infections occurred among young people aged 10 to 24, with 140,000 of those being adolescents aged 10 to 19. Yet, we do not have policies in place that best allow them to access services, including the age of consent. Delegates, for us to be able to actually fully engage young people, we need to understand where are the gaps at the moment. So I've highlighted some of the gaps we have observed over the years with the work we do as DARE and community advocates. One of them being limited youth participatory structures in sexual and reproductive health policymaking. We talk a lot about how adolescents and young people are highly affected by most of the issues we are addressing today. However, if you go back to our specific countries, we still are lacking national platforms that can bring together the voices of these young people and coordinate them to facilitate an environment where they can fully engage. Additionally, from my observation and experience being a young person, as I am graduating as well, I've noticed there's an issue around having sporadic engagement where young people are only engaged at the very beginning of processes, and as processes get to higher level, the likely you will find less numbers of young people engaged, if lucky. For us to be able to have an ideal engagement for young people, we want to be sure that it's consistent and progressive, meaning young people are able to engage at all levels, including community level as well as high levels. We also have limited capacity of young people to enable meaningful engagement. With that, I mean, it's one thing to invite a young person in a room and have them sit. It's another thing to have them invited in a room and have them speak. But also it's very important, and I think this is an element that we normally forget, to get them to understand exactly what is happening in the rooms. We have a lot of young people, we have a lot of young people going into these spaces not understanding what exactly is going on. And this could limit the power of the solutions they could actually propose. And it's also important how we translate the information, perspectives, and opinions of young people into action after they engage. So we're moving from having young people invited in the rooms for checking boxes, and how we have young people participating to check boxes, because the room would not even provide the space for them to seek clarity prior to engaging, to making sure that they can meaningfully contribute to discussions going on. With the fast growing digital advancements as well, another challenge is around how we have an equal access to digital technology. Delegates, we understand how during COVID, we quickly shifted from using physical platforms to digital platforms to get most of our work going. Unfortunately, this has left out a lot of adolescents and young people, specifically adolescent girls and young women, due to limited access to smartphones, but also limitations with data affordability. Last but not least, it's around financial resources. We understand how in our countries we have different geographical locations, and most times most policy discussions would happen in cities away from our home cities. For young people to engage, they would require transportation, but also like being able to afford accommodation, and this can be a barrier for most of young people to attend. Additionally to this, we know very well how underfunded youth-led movements are, and this can also affect how young people-led movements can mobilize young people to fully engage in these processes. So for a moment, I would like for us to reflect together. In all the work that we do and the spaces that we are a part of, how are you engaging young people in your respective role as part of sexual and reproductive health response? Do you have young people in the decision-making rooms? How well do these young people understand what they are doing in these rooms? Do you get the chance to fully take them through what they're supposed to do in advance so that they understand what they're meant to contribute to, but also making sure that they understand the power of their voices and leadership in those rooms? Perhaps these questions can help us do better and change the way we're practicing. Next. So I've laid down a few recommendations for us to utilize in order to improve our practices in how we engage adolescents and young people in policy development and review, as well as implementation processes. I think it's time for us to intentionally establish comprehensive frameworks and platforms to facilitate diverse youth engagement, recognizing that young people are not a homogeneous group. So it's very important for us to make sure there is a diverse representation of young people, including young people living with disabilities. But also, most importantly, We need to be intentional about creating these spaces and allowing young people to actually, lead these spaces and being able to coordinate and integrate them in the existing government and high-level systems to be able to actually get information and feedback from them and be able to actually respond to it. It's also very crucial for us to prioritize mentorship and intergenerational learning to foster knowledge transfer. One good example of this for me would have been recently I've been a part of the African Women Prevention Community Accountability Board. It's a space full of young women advocates, but also seasoned advocates, together collectively working to push for political will as well as financial investments in making sure that we have diverse HIV prevention options that speak to choice. For me, in this space, it's the leadership of young women that stands out. And I think if we're intentional in doing the same, to making sure that whatever we're working on, whether it's calling out for political will or creating policies, we make sure that we have intergenerational seats available for adolescents and young people as well. That way we can learn from each other and create policies that speak to the current real-time needs of the communities we're serving. It's also important for us to invest significantly in enhancing the capacity of young individuals to actively participate. Don't assume we know it all. We understand the issues we are facing, but we understand how complicated the language and policy development can be. So it's very important to make sure that we're able to break that down for young people to understand exactly what they're supposed to do and trusting in our leadership. Also extend support to youth-led initiatives and organizations, acknowledging their unique perspectives, but also leveraging digital advancements and innovation to create more accessible and inclusive platforms. And by this, I mean, it would be terrific to come across non-data using, non-internet using platforms where anybody can be able to access and being able to engage in discussions. Next. So here's my call to action to you all today. We need to understand that youth sexual and reproductive health landscape differs notably. You cannot compare the needs of young people in Western Africa and Central Africa to those of perhaps Eastern and Southern Africa. So there's a need for us as we are moving forward to making sure that we're able to fully engage young people in policy development and implementation processes. We are able to have country-specific data to inform and shape targeted policies to be able to support the diverse needs of youth and unique needs of these youth in different countries. Along with that, it's important for us in our respective role to be intentional in making sure that youth actively engage in decision-making platforms throughout the processes, recognizing the lasting benefit of prioritizing our perspectives. We do not want to be receiving end products of these policies. We want to generate them with you. And I think it's important we create that space now. And last, ensure culturally sensitive, multisectoral, and inclusive engagements that address root causes like poverty, limited education, and gender-based violence, because we know very well these are the issues that exacerbate risk for most of sexual and reproductive health issues affecting adolescents and young people. Asanteni sana.
Thank you very much for that, Dr. Lilian. Our next speaker is Professor Quarraisha Abdool Karim, who's the Associate Scientific Director for Center for AIDS Program for Research in South Africa, CAPRISA. She's also the Pro-Vice Chancellor for African Health University of KwaZulu-Natal in South Africa. We know Abdool as an infectious disease epidemiologist over a year, spending over 30 years working primarily in the area of prevention. And today she'll be giving us a talk, talking about finding the missing target, what more to do for HIV, TB, STI, and hepatitis. Over to you, Prof.
Thank you, Dr. Shlobo, for that very warm and generous introduction. Greetings, distinguished guests, friends, and colleagues. It's a real honor and privilege to have this opportunity to address you this morning on the topic of finding the missing targets, what more to do for HIV, TB, STIs, and hepatitis. The title alone is quite a mouthful. And I have exactly 15 minutes, as Dr. Shlovu reminded me. Even though we come from Durban, KwaZulu-Natal, I'm not going to get 1 minute more. So I want to just make the point that these are not disparate and distinct epidemics and pandemics that we're talking about. They are all interconnected and interrelated. The STI epidemic impacts HIV transmission, but also treatment success. We know with advancing HIV disease and in the absence of antiretroviral treatment initiation, one of the most common opportunistic infections is tuberculosis. And we know neglect of TB has led to MDR and XDR TB. And then we have a growing substance use and injecting drug use problem in sub-Saharan Africa. And that comes with exacerbates an already extensive hepatitis B epidemic, pandemic, if you like, and the threat of a growing HCV epidemic. So by way of overview, what I thought I'd do is, given a lot that needs to be covered, is to go back to basics. When we're dealing with epidemics, what do we need, and what is this pathway towards control or eradication? What do we need in terms of measuring that we're making progress? And what's the difference between goals that we set and targets that we use to measure progress? And then while the technologies that we have and interventions and evidence-based interventions are an important starting point, there's a big gap between and a very complex gray area that we need to traverse before we can achieve our desired goals. And I'll talk a little bit about a human rights framework, universal healthcare, and make some concluding remarks. So I also want to thank my colleague here who's doing the sign language translations. And I can imagine having to process a lot of epidemiological and scientific terminology. You're doing a great job. Thank you. So, yeah, big round of applause. So as we think about infectious diseases, one of the first things we need to know is who's infected and who's not infected. And in order to do that, we need good diagnostic assays, not just good diagnostic assays that are sensitive and specific, but also available and accessible where you need to do the testing. With the epidemics, you start with outbreaks, and outbreaks then go to epidemics, epidemics then to pandemics. But at least for things that we know, having good diagnostics is important. Then if you test positive, we need to have effective treatment and we need an effective cure. If you test negative, what are the prevention options, including vaccines, that would enable us to then prevent infection? Then I'm going to come back to this black box or red box. And then what we're trying to do is get one of three things, which is low endemicity, control, or elimination or eradication. The next slide, please. So what I've done here is taken each of the disease conditions or each of the infections, and I've put a green where we have something, and I've put an amber when we could do better, and red if we don't have this. So if we look in terms of diagnostics, we do have diagnostic assays for all, for HIV, for TB, for STIs, for hepatitis infections. The challenge is how good are they? And are we using it in terms of diagnosis and triaging appropriately? In terms of treatment, we clearly have treatment for HIV, HPV, HCV, and I put a question mark about TB and STIs because we have to consider extremely drug-resistant TB, multi-drug-resistant TB, and with the STIs, we need to be considering antimicrobial resistance for the STIs, and then the viral STIs, again, question mark. In terms of an effective cure, we do have that for HCV, we do have that for TB and STIs. We don't have that yet for HIV or hepatitis B. In terms of prevention, we have options for all of the conditions that I'm talking about. But in terms of effective vaccines, we only have an effective vaccine for HPV. We have a good BCG vaccine that is amazing in terms of preventing TB meningitis, but doesn't do too much in terms of preventing adults getting TB or young people. So there's gaps there. And I just want to say, when you look at these greens and reds, we immediately need to be thinking about where our advocacy efforts, where do we need to direct it in terms of gaps that we have in technologies. And then if we look at what we have, what is it possible to achieve? Well, with HIV, TB, and STIs, it's possible to get low endemicity and to some extent control. And that in terms of elimination or eradication, that's only possible at this point in time for hepatitis B and hepatitis C. So we can go on to the next slide. And I just want to use this to illustrate what we need in order to be able to diagnose, prevent, and treat. And while we may have this array of tools for HIV, I wanted to just remind us, 40 years, we've just celebrated World AIDS Day. We've reminded ourselves about how much more that needs to be done. Some 35 years ago, it took nearly 2 weeks to get an HIV test result. And then you had to do confirmatory testing with Western blot that took even more time. And then we had the PCR technology, but it wasn't until we had rapid HIV antibody assays that we were able to transform how we manage and respond to HIV infection. And we see that over and over again, the importance of rapid diagnostics that are very sensitive, that are very specific. Now, we also know in epidemics that population, place, and context matters. We were reminded about that just now by Dr. Lilian. And so when we have an array of options, we allow choice and we allow smart combinations to be possible, because what we're dealing with may be one epidemic or interconnected epidemics, but what's needed in different geospatial settings, depending on drivers, may be different. So if you have this whole toolbox, you don't take that whole toolbox and go like a sledgehammer for a nail. You have to choose from there what are the appropriate combinations and develop bespoke and tailored approaches in terms of how we utilize this important tool that we have. May I have the next slide, please? I think while in HIV we've made a lot of progress, we've also been reminded, particularly in sub-Saharan Africa, the history of neglected diseases. And that's no more apparent than if we look at the TB treatment and the TB epidemic, which continues. And it was the identification of extremely drug-resistant TB in a setting where ARV treatment was being provided. That was a sharp reminder of the infectiousness of TB and the limitations of the treatment that was currently available. And then we saw a huge investment in terms of new treatments for TB, and now where we're actually getting ready to be evaluating vaccines that would enhance what BCG does. The next slide, please. I'm going to go on now to our goals and share with you. Next slide, please. Some of the goals that have been set within the context of SDG 3 and the UN Sustainable Development Goal Framework. And you can see for HIV, we have 3 zeros. We know that very well: 0 new infections, 0 stigma and discrimination, 0 AIDS-related deaths. We have also targets for TB. We have targets for STIs and hepatitis. And I don't want you to read it, but when you have time, these slides are available. It's to see how broad some of these targets are and how ambitious some of these targets are. And when targets are set and goals are set, they do need to be aspirational, and they do need to be bold, and they do need to be courageous. But when we set targets, we have to ask ourselves, are we able to measure that? And if I could have the next slide, please. And this is what our goal is. And then we look here, we have targets. And I want to say for each of these conditions, we have targets, but we have to, as we measure this, take into account that it's not just the mere number, but we do need to have a very granular understanding in terms of age, sex disaggregated data, geospatial location. And I mean, this slide just makes the point that while we have these targets and we have 2025 targets, and in some instances we have data from 2020 and in other instances from 2022, and we have the 2025 targets in black, that we off target. We know with the midterm review of the SDGs how off target we are, and these just highlight the gaps that need to be closed. And we can attribute some of these being off target to COVID-19, but I don't think we can attribute everything to that. We do need to take a critical look at this and identify where these gaps are. My next slide, please. And it's important because we do need to know our epidemic at a very granular response in order to really have an appropriate response. And in all of this, science and scientific evidence is central. And we can see how these hotspot data tells you that although we have a generalized HIV epidemic in sub-Saharan Africa, it's not equally distributed. We have generalized epidemics and we have hyperendemic epidemics. We have success in some areas and not. And within a district, within a ward, you can see differences. And we really need to understand that as we get to this last mile in our HIV response, and we try to do better in terms of TB, hepatitis, and other STIs. And I think our UNAIDS report from 2016 on Let Our Actions Count is very important. But it's also important in terms of taking on misinformation and in terms of disinformation. May I have the next slide, please? I think in our HIV response, we have taken one target, which is 90, 90, 90, which was the 2020 target, and now 95, 95, 95 as our 2025 target. And we've really made our response centrally around this. And the question we need to ask ourselves, does 90, 90, 90 translate to the desired incidence rate that we want, which is less than 1 per 1,000, so that your R0 prevents further infections taking place and gets you to a level of endemicity or potentially control? And we have this wonderful data that tells us that we're reaching this in many countries. It tells us globally which are the countries lagging behind. It tells us where we need to put more attention, who's getting it. But it doesn't answer the question, do meeting these targets actually prevent infection? And we have disconnects when we look at different data sets. When we do clinical trials, we see in countries that have achieved 90, 90, 90, or even 95, 99, 95, we still see high incidence rates. But importantly, I wanted to highlight in this slide that as we have treatment, we have had a lot of innovation. And that's important when we have one discovery, is how other discoveries follow. And there's no room for complacency, and all these innovations that take place that enable us to do better, make sure that we have better uptake of the interventions and better persistence in use of the interventions. May I have the next slide, please? I now want to move on to closing the gaps, and may I have the next slide, please? And here I want to talk about this piece. When you have good diagnostics, good prevention options, good treatment options, what more do we need? Because we know just having those tools is not adequate for reaching the desired goals. And here, I think we start to unravel some very important insights. Lilian alluded to some of that. And I'm going to talk about effective UHC. I'm going to talk about access and not leaving anyone behind, about political will, and about affordability. And the importance of everything we do is, who is it for? And who are the populations who will benefit from it? So we can't go to the populations when we have things in our hand. They are a key part of knowledge generation, and co-production to ensure high levels of uptake. And so may I have the next slide, please? And these list many of the challenges that face us, some of the gaps. May I have the next slide, please? And I just wanted to show you something in terms of hepatitis B. Okay, I have 5 minutes, but my slides are not moving fast enough. So I'm just going to say the same thing, which is maybe to make the point. We have a very efficacious hepatitis B vaccine. In fact, it was approved in 1981. South Africa adopted this in 1995. And if we look at the countries in sub-Saharan Africa, there's only 7 out of 40 countries from the Gavi Alliance that have birth dose programs. So having a tool that is not being rolled out and reaching populations who can benefit from it makes very little difference. May I have the next slide, please? But I think it's not just the tools, it's also about consistent political leadership and community engagement. And I think doing things with people and not on people adequately captures that. May I have the next slide, please? And I think when we are actually implementing things, we do need to understand behaviors. And that's unfortunately in many of our epidemics that we're dealing with, that I'm addressing this morning, has actually been under-researched. And we don't know enough about how do we bridge this particular challenge about knowing and actually doing. You know, when you have children, you learn very quickly. They do what they see, not what you say. So I think also countering things that are like scare tactics, but how do we change behaviors and how do we support behavior change? And that can't be done in the context of human rights violations on the basis of gender, on the basis of particular professional choices or practices. And then the next slide, which is about scaling up UHC. And I think we know how treatment access has changed that. And if I may have the next slide, please. May I have the next slide, please? Now, I want to say 3 key lessons and underlying principles as we move forward. In order to bridge these gaps and meet the targets, is about leaving no one behind, and that includes fighting stigma and inequalities. It's about evidence-based strategies. It's about effective implementation targeted for priority areas. And this means for HIV, for example, recommitting to treatment as prevention, but moving beyond 95, 95, 95. Provider-initiated PrEP provides a new PrEP technologies, provide us a new opportunity. But as we continue to strive towards reaching our goals, we have to continue to innovate. And may I have the next slide, please? And in conclusion, in pandemics and epidemics, scientific evidence has importance in decision-making, providing guidance and challenging misinformation. In AIDS, consistent political leadership has strengthened our responses, and scientific evidence has provided a path forward. However, equitable access is key to ensure that everyone is safe and benefits from advances, investments in research, infrastructure, and healthcare key delivery. Important lessons on the cost of incomplete epidemics include emergence in COVID-19 of variants of concern, and I've already touched on TB. But I just want to end by saying that the HIV and COVID-19 pandemics have provided us a new lens for understanding the nexus between science, politics, and global health as we pursue the path of the Sustainable Development Goals. And if I may just end with the last slide, which is the importance of mutual independence and shared responsibility, and how global solidarity has got us to this point, and that if we keep reminding ourselves in epidemics and pandemics, no one is safe until everyone is safe. Thank you very much. Thank you.
Thank you very much, Professor. That was a difficult one for me, but thank you very much for that. I think we will, managing time, go straight to Dr. Ruth Laibon-Masha, Chief Executive at National Syndemic Disease Control Council in Kenya, and who will be talking to us from boutique to systemic and sustainable scale-up, the case for HIV prevention. And she's currently, she's been working there since September 2020, and work has focused mainly on HIV, human rights, gender, and sexual and reproductive health, while also serving in different capacities at different levels. She's got a PhD in public health. Over to you, Dr. Ruth. Thank you.
Thank you very much, and I'm privileged to speak after a presentation that's really given us all we would like to know about prevention. I'll do injustice in this presentation if I don't acknowledge three people. One is a bar, the owner of that bar, and it's long closed, and then two other colleagues of mine who sat with us in 2011, having a drink and asking ourselves what was wrong with the HIV prevention in our country, that is Kenya. And we sat down and drew the report and asked ourselves, so what is it about? What is our business model? And in that bar called Caribana, we said, actually, we are just in a business of investing in preventing infection, making people have viral suppression, and addressing the HIV-related deaths. And we came with a terminology that we coined: spray, hope, and pray. That is how we defined our status of prevention then. And we asked ourselves, what does this boutique look like? We have so many things going on, so many actors, but there seemed to be something wrong. And we were quickly confusing progress to become success. The famous quote from Warren Michel of IVAC, he says, do not confuse progress with success. So we had programs that were siloed. So there is, please look at me. Okay, good. There were programs that were siloed. We had prevention that was basically, we only stopped speaking about biomedical, but only complaining that we're not investing in the other interventions. Then we were not scaling up innovations. Every time there was a new kid on the block, we would abandon that and go to the next one. And that the prevention was highly, not only dependent by the donor, but also donor priorities. So if somebody came and said, I'm giving you money for PrEP today, would abandon the condom and move to the PrEP. And that was a song that we were all singing. So we said, let's sit down as these first three people and try and see if we could influence our country to shift how they do prevention and come up with a sustainable case of investment that we can come back years later to examine and see what will change. And so we began to think differently. We said, first thing, we must have clear goals. We must not adopt one size fits all. And we said we had inefficient delivery platforms. Decisions were not being based primarily on the data. We did not have a shared responsibility. No one would have a sleepless night just because 1,000 new HIV infections have occurred. And that also sometimes happens in most of our countries. You know, if no one is asked what happened, why is your intervention not working? And then, of course, the other element was the subnational level was only waiting for the national level to kind of program and be accountable. So the first thing we did to think differently was to ask ourselves, who is this person who needs prevention? And what do they need? What is available? How will it be delivered? And what will it cost? And then we realized then we needed to move from thinking about the national to what we call subnational clusters. And we realized that the data was telling us a different story. Whereas we are everywhere in the country, we had cohorts and geographical locations that HIV and populations where the HIV new infections were concentrated. So we divided, the first thing we said is that we have a very high incidence area, medium, low incidence clusters. And then we said that the next thing we're going to do is to use our data to granulate that data, and not only the data that comes at the end of the year, including our program data. And then we said that our vision for then 2030, we are speaking about 2011, 2012, 2030, we'll be looking at timely incident surveillance. We didn't know these things were going to come. And then we said, let's move from interventions to focus on the population and what they need. So by age group, by priority population, and by bridging populations. And then we said, let's look at how we can deliver the combination prevention. And we said, we'll bring targeted packages. Let's define them. What does a group need? And then we needed to think about how will we translate any new coming. And at this point, there was not even ARVs, for all. And we are speaking visionary, looking at 2030. And we are speaking about how will we translate a new product into a large-scale public health program. How are we going to coordinate ourselves to be able to take these things in? And how are we going to stop just relying on the health sector and ensure that we move along in the next 10 or so years with other sectors, that we are leveraging on the political structures. We are also ensuring that the legal reforms are not being left behind. And this context is where we were then, 1.6 million people living with HIV, and the prevalence was about 6%, and about 191,840 new child infections. We then realized that, that if you look differently into these new infections, and you looked at the subpopulation, 21% of the adult infections were actually only premised between the ages of 15 to 24. But then we also looked at the child infections. They were very high, 13,000 at that time. And then we then looked at the adults' new infections and realized that they were also primarily being driven by the key population. At the geography level, we realized that out of the 47 national systems that exist, and they had semi-autonomous, 65% of all the new infections was only in 9 of those 47 units. The next thing then we asked ourselves is how will we look at that data for decision making, and how do we improve how we translate our own local research solutions into the national program, because that was lacking. The country is one of the countries where everyone is coming for a pilot. They pilot this, they give success, they would go to New York, we translate that into a research document, disseminate globally, and move on. And the new prevention technology. And at that time, we were looking at multi-purpose prevention technology. What is coming in the future? What do we see in 2030? And then based on that, we then drew an investment case to convince the country this is the way to go. And we said, if we do business as usual, the hope, spray, hope and pray, we are going not to get anywhere. So let's give this investment case. We began to show if we change the direction, we'll be able to save more lives, and we actually model to see how many new infections would avert by that model. This is a curve, the previous slide, please. This is what then, how we've been able to look at what happened since that 2013 to date. In the end, we've seen that we've reduced HIV infections everywhere by an average of about 78.2%. And that probably is attributed to many other things, but most importantly, it is attributed to the fact that, next slide, the fact that there was a focus on one section of those priority population, which is a key population. In fact, the contribution of new HIV infection from key population moved from about that 3% that was modeled then to about 13% by 2013. So we now attribute the strong key population program as having a catalytic kind of drive towards what we then began to see. But then we are realizing something, despite all these efforts, and despite the fact that globally we've been talking about that we can treat ourselves out of this epidemic. Last year, we had the 6th highest number of AIDS-related deaths globally. So we are asking ourselves, what's going on? And we began to realize that the same way we have done for the data for prevention, we need to also dig deeper on this data for treatment. And what we are finding is that treatment interruption is real. Last year, we had about 134,000 people who disrupted treatment. Out of those, when you go keenly into the data, you find about 6,000 of them are dead in that 1 year. So the question is, How do we make sure that the treatment as prevention is also working while we are also thinking about doing prevention differently? And these numbers you can see in 2023, although they are fewer, they are still high numbers. And so what lessons have we learned that we can really share quickly? We have learned that we have to change the way we do business even now. We have to examine the interventions we are doing, and we have to look at the determinants. And one of the challenges we are facing as a country is a triad challenge of new HIV infections among adolescents and young people. And they're being driven by sexual and gender-based violence. And again, when you look at that data, 36% of all sexual and gender-based violence reported in the facility are from the children ages 10 to 17. So this tells you there's a problem. When you follow that cohort deeply, you're going to realize that those who come to report, those who are given post-exposure prophylaxis, the outcome of that number, which is from 15,000, you get about 112 cases of new HIV infections from the cohort that you gave PEP. So the question is why? What can we do differently? So we have learned that one, we need to apply precision and differentiated HIV prevention approach based on the incidence prevalence and changing epidemic typology. In 2013, only about 4 of those devolved units had a concentrated epidemic. In 2023, 22 of those 47, what they have now is a concentrated epidemic. And what is going on here is that we are still treating it as a generalized epidemic, but you look at the transaction sex that is happening between the young girls and the boys ages and young men aged 20 to 29. You can almost see who is their sexual partner. Then you realize that the sex work is moving towards where the infrastructure is moving. Development, roads are opening, sexual networks are expanding. What do we do differently? How do we tell these people that you've been telling them that they are low incidence areas that you need to watch because your sexual patterns have changed? Your men are traveling to the main capital within a day, and then they go back to the place where you had close polygamous relationship, and now you're taking the new infection there. So we are looking at now, how do we then apply the data that we have from the program differently to ensure that we still are able to take that curve down. The other place is to sustain effective interventions for key population. And we know very well that this has been the anchor of our country program. The challenge has been, of course, the clawback of the legal environment, but the whole public health approach of deciding to focus on this population still remains. But even among this key population program, we are still conducting epidemic appraisals to guide us in terms of who is this also within the key population cohort is able to transmit or already is viral suppressed. When you look at people who inject drugs, their access to treatment is much, much lower than the other key population. So we've begun to check on that. The other one is to look at tools to measure the quality and coverage and impact of intervention. This has been said by the previous speaker. Look at what is going on with the PrEP program. You can see that whereas we have highs, there are so many lows. Can you call this a successful program? Is this that the discordant couple is stopping being at risk at one point of their relationship? What's going on with the sex workers? Why is this up and down curve happening? Then the other element is that we have learned that unless we strengthen the community-led HIV prevention services, we'll still have a challenge moving forward. And we are looking at how do we get paid up community. We don't want to confuse community health promoters, the volunteerism, and the stipend that we're talking about with the peer-to-peer models that have been established for populations that require a different form of model of peer-to-peer. Then again, we're also looking at how do we advocate for domestic funding to be given to communities? When we speak sustainability of the HIV response, how will we sustain the communities led by MSNs who are already illegal in our context to be able to continue doing this wonderful work they have done for us to reach the decline from 33% contribution to 13%. We have to create a supportive environment for non-governmental organizations. Government have to accept that we are not strong everywhere. We have to accept there are areas that we need non-governmental organizations. So with or without funding from donors, something has to come out from the domestic resources. And then integration. The one question then we are asking ourselves, is it the other services that should come to our HIV vertical program, or is it the HIV vertical program that should find its way into other services? If you have a cohort of 800,000 people who are older people, are you waiting for the diabetes, hypertension clinics to come to you? Are we going to take the HIV services there? Interesting, in our last year data, we realized these new HIV infections in the older cohort, 50 and above, actually until 70, that is rarely spoken about. And these people, they are inpatient most of the time, and they will never be found. So how do you make sure that the prevention discourse is actually helping the entire health system to respond? Then intra and intersectoral integration. We need to think about what you're calling the multi-sector differently. The prevention program, we have 1 minute left, that's fine. And then also looking at the non-health sector. We also need to improve utilization of program data. There is so much program data lying within the country. Everywhere you go, there's a program data, including just the diagnosis data. It actually can be able to tell you where your last 1,000 new infections came from. And this is data that doesn't have to wait for a huge kind of preparation like what you do the estimate. The last speaker talked about the adoption of HIV prevention choices. Our question is, how well are populations being prepared for some of these new technologies? For example, we know the myths of family planning, that if you get an injectable, you're going to grow fat. How are we addressing these myths before even a tool comes in place? Injectables, what are some of the things that, it's a previous slide, please. What are some of these things that we must already focus on and make sure that the communities are already prepared to take in this new technology and tools? And then finally, I don't want to speak about what has been spoken, but most importantly is not to abandon what works. For epidemics like Eastern and Southern Africa, we will be not doing ourselves justice if you're forgetting condoms. We are moving away from one tool that has been so effective over the years and looking at the new tools and the new key emerging products without carrying the condom alone. And then the other issue is, how do we leverage on the development synergies without necessarily looking like the HIV program is the one that is going to do it? We must be able to give each of the sectors that are of our interest an indicator that they will be able to look at and contribute to the HIV response. And the only way is for them to be part of our accountability mechanism. And finally, I think the funding has to be prioritized. Interesting, and this is my last because I'm over time, but you looked at our next, when you looked at our funding situation, we realized that in the year 2023, only 9% of the funding went to HIV prevention. And then with that, where did the money come from? The money also came from the same external resources. So if we have to change what is going on, we must also try to begin to ask ourselves, how will we prioritize the funding differently? Thank you very much.
Thank you very much, Dr. Masha. As we wrap up this morning's session, our apology for the time that seemed to be running out of all of us. But we just want to say thank you to Dr. Mwakyosi for that speech, particularly around the issue of young people and coming from a young leader. I think let's give you a round of applause. It's really good. Thank you. Also, thank you to Prof. Abdool Karim, as you're reminding us of going back to the basics and being able to look at where we are and what do we have at this point in this journey. Lastly, and let's give you a round of applause as well. And then lastly, Dr. Masha, you are reminding us, you're telling us being systematic and sustainable, being able then to control the epidemic at a country level. Thank you very much. As we wrap up, I think we also would like to acknowledge our award for today, Dr. who, she, young person again, and that's what is good. She submitted a title of the abstract was Differentiated Service Delivery Program monitoring during scale-up, a description of innovations from Zimbabwe between 2017 and 2022. She is a public health specialist, and that is Dr. Quarraisha Kwanzura from Zimbabwe. And we'll have, and she can come up for the award. She has 10 years of experience working at various levels in Zimbabwe in the Ministry of Health and in the childcare in Zimbabwe. She's responsible for the differentiated service delivery implementation for people living with HIV on ART, TB, and HIV collaboration at national level. And it's also a focal point for community collaborations in which she works with civil society organizations and organizations representing people living with HIV. She's a medical doctor, and she holds a master's degree in public health from the University of Zimbabwe. Coming up front would be Luke, who will be presenting the award.
Thank you so much, Madam Chair. Before we present the award, I would like to highlight here that for ICASA 2023, you receive a total of 2,600 abstracts. And out of 2,600 abstracts, we review 2,540 abstracts this year. I will also want to inform you that 1,647 abstracts has been rejected. I will call here that all the reviewers, we should really thank them by giving them one round of applause, because they did a fantastic job this year. And we presented here 78 oral abstracts. You can go to the booth there, you will see at the exhibition site, we have 815 abstracts presented every single day. Saying that, let me also thank all the speakers, especially Dr. Abdool Karim, Quarraisha, that came from Japan just to present at ICASA 2023. Please, can we applaud all the speakers once again? I'm proud to give this award to her because it's happening that she's from Zimbabwe, right? And really, for the host country, we are very proud of that. If you remember, the first abstract, track A, the person came from Benin. Benin is my host country. We don't plan that, but it's based on really the result of the abstract reviewers. They are the ones that mark up the abstract, and they are the ones that select the best abstract. Félicitations.
Thank you very much. We'll then stand up for the photos. And thank you very much to all the people who attended this session, the plenary. Thank you very much.